Good evening, folks. I have your discussion C for tonight. We are discussing the latest in palliative. Here we go. Palliative care journals. Round down. What's new? What's new? What matters? And why it's shifting the field. The date is February through March 2026. Across the major journals, a clear pattern is emerging. Palliative care is moving earlier, becoming more equally attuned, and leaning heavily on structured communication frameworks to prevent non-beneficial burdensome care at the end of life. The research is less about adding services and more about reshaping the culture of decision making, from ICU thresholds to hospice referrals to the micro skills of symptom relief. Below is a richer, more contextualized synthesis of the latest findings. High impact studies you should know about. One, limiting non-beneficial life-prolonging interventions. JAMA Network Open, February 26. This quantitative study digs into how clinicians actually make decisions when the medical team is drifting toward interventions unlikely to help. Think late stage intubulations, intubulations, repeated hospital transfers, or suggestive aggressive treatment in the final weeks of life. Why it matters. Clinicians often know an intervention won't help, but lack a shared framework to say so. Teams that use structured decision pathways anchored in prognosis, patient values, and transparent communication dramatically reduce unwanted high burden interventions. The study reinforces what many palliative clinicians already teach. Clarity prevents suffering. Practical angle. This is the kind of research that justifies embedding communication training into hospital lists and ICU workflows, not just palliative consult teams. 2. Hospice access disparities among low-income cancer patients. JAMA Network Open, January 26. This analysis goes beyond the usual social determinants matter. Framing it examines how class, culture, capital, stigma, and mistrust shape hospice uptake. The key insights: patients with few resources often encounter hospice only after a crisis. Misconceptions: hospice means giving up. They'll stop all care. Remain powerful barriers. Structural issues: transportation, caregiver availability, insurance, literacy are as influential as clinical need. Why this is a big deal: it reframes hospice disparities not as patient preferences, but as a systematic inequity which demands policy and community level solutions. 3. Symptom focused low resource interventions. Springer Palliative Supportive Care Roundup, March 26. March 2026. This collection highlights practical replaceable interventions. Delirium trajectory mapping to protect, prevent distress. Hand message: improving pain, anxiety, and sleep. Simple, low cost, and culturally adaptable. Advanced directive coaching that actually increases completion rates. Why it matters: these are interventions that frontline staff, volunteers, and families can use. No specialty team required. They democratize comfort. They democratize comfort. 4. Special issue: new advances in palliative care, March 2026. A curated set of studies on early identification of palliative needs and chronic illness, caregiver burden and resilience, education models for primary palliative care, technology-enabled symptom monitoring, use cases. This is a goldmine for curriculum builders, program directors, and anyone designing community education or primary care-based palliative initiatives. 5. Practice and policy briefs. CAPIC, BMJ, supportive palliative care. These pieces translate research into implementation guidance. How to teach primary palliative care. How to structure consult triggers. How to build equity into referral pathways. Cross-cutting themes emerging across journals. 1. Earlier integration is no longer optional. The evidence is overwhelming. Early palliative implement reduces crisis admissions, improves symptom control, and aligns care with patient goals. Equity is now a core clinical competency. Hospice and palliative access disparities are being reframed as structural failures, not patient choice. Journals are pushing clinicians to consider class, culture, and stigma as clinical variables. 3. Communication frameworks are the new clinical tools. Scripts, decision aids, and structured conversations are being validated as interventions in their own right. 4. Low resource interventions are getting serious attention. Message music, massage music, delirium monitoring, and caregiver coaching are being studied with rigor and showing real benefits. Implementations for clinicians, educators, and families with a Pennsylvania lens. For clinicians and hospital teams, adopt brief decision-making frameworks from the JAMA study to reduce non-beneficial ICU transfers. Use early triggers for palliative consultants in clinic and chronic illness, not just late-stage cancer. For hospice and community programs, screen for social detriment barriers during referral. Partner with local services, faith communities, and transportation networks. Offer culturally attuned hospice education sessions to counter stigma. For educators, and program directors. Integrate MDPL and CAPC teaching modules into nursing, social work, and primary care curricula. Teach communication frameworks as core clinical skills, not electives. Ask what outcomes matter most to the patient. Document preferences in an advance directive and share it with primary care. Use low resource comfort strategies, massage, music, routine orientation cues to support comfort at home. Limitations in what's still missing. Many studies are quantitative or single center. Generalization ability is limited. Workforce shortages and reimbursement constraints remain major barriers. Equity research is growing, but interventions to fix disparities are still underdeveloped. More work is needed on moral palliative models, highly relevant for communities like Meadville. Okay, guys, that's your C for the night. I will see everybody tomorrow for shows, or if I decide to jump on later and do an extra. We'll see. For now, Gator Wellness. Take care, folks.